My name is Rebecca Gibson, and this is a photo story on the fluoroscopic exam called a small bowel follow-through, or SBFT. This is a contrast study used to determine the motility of the small bowel. Oral contrast, usually barium, is given to visualize the anatomy of interest, and pictures are taken at intervals to watch the contrast move through the bowel. We'll start from the beginning of the patient's care that led to the small bowel series. A patient typically presents with some type of abdominal pain. This can be any region or quadrant. Other symptoms leading to an SBFT may be constipation, diarrhea, or vomiting. When the patient visits their physician about these symptoms, their doctor may or may not recommend an SBFT. With this order, the doctor will also prescribe what's called a prep kit. This prep kit will attempt to flush the patient's system prior to the exam to allow for an unobstructed view of the patient's bowels. The patient will also be asked to be NPO after midnight prior to the exam. NPO stands for nil per os, which is Latin for nothing by mouth. Again, we don't want anything obstructing the radiologist's view of the anatomy. The patient will be scheduled a date and time for their exam in a radiology department. This could be an outpatient clinic or a hospital. Upon arriving to the clinic or hospital, the patient will be checked in and the technologist will be informed of their arrival. The doctor's orders must arrive prior to the patient's exam or be brought with them. The technologist must view the orders themselves to ensure the correct procedure is being done. Once notification of the patient's arrival has been given to the technologist and the orders have been verified, room preparation should begin. If the room's fluoro and x-ray tube haven't been warmed up, this should be done now. An x-ray room with both a regular tube and a fluoroscopic tube should be utilized. The technologist should prepare the table with a sheet and pillow for the patient's comfort because they may be here for a while. The rest of the supplies should be pulled out of storage and placed in the room, but not opened until the approval of the radiologist is given to conserve materials. Once the technologist brings the patient into the room, they should prepare them for the procedure by explaining the exam step by step. After the explanation, answering any questions they may have, the technologist will ask if the patient would like to continue. If they say yes, this is informed consent. They aren't required to sign any forms for this procedure, but their agreement and continued compliance implies consent. Next, the patient should be placed in a gown. All clothing should be removed and the gown placed open to the back. Only socks can be left on and underwear if there is no thick elastic, metallic parts, or glitter. After getting the patient on the table, the first image to be taken is called the scout image. This is done before any contrast is administered. That gives a baseline for the study and allows the radiologist to see if the prep kit worked well enough. All abdominal images in this study are taken on 14 by 17 cassettes or films and marked in the inferior corner with a right marker on the patient's right side. This image should be centered to the level of the iliac crest and annotated or marked with lead markers as a scout image. The scout image is then sent over to the radiologist for review. He will decide after looking over the scout image if the exam should continue. The radiologist may decide not to continue the exam if the patient hasn't been adequately prepped. Once radiologist approval is given for the exam, the technologist can prepare the contrast. Sites may differ on what type, brand, or form they stock and prefer for their exams. The most common form of contrast for this study is barium. Shown here is the one that I've used most often, brand name InterView. This comes in liquid form already mixed. The barium must be shaken thoroughly before use though. Barium can also come in powder form, where the technologist must mix the powder and water as per the directions prior to the exam. Another common type of oral contrast utilizes iodine. Iodinated contrast can be absorbed into the body and is more desirable when there's suspected perforation or an upcoming surgery. No matter the type of contrast used, the patient will ingest the contrast, so the technologist should have a few cups on hand. The radiologist will decide on the amount of contrast to be given to the patient, and that amount should be ingested by the patient as quickly as possible. Once all of the contrast has been ingested, the technologist will note the time and take the first or initial image. This image is centered higher to ensure that the stomach is shown in its entirety. Initials should be placed on the image either with a lead marker or with computer annotation. Images will be taken for the next hour in 15-minute intervals, and the second hour in 30-minute intervals. At the end of the second hour, or when the technologist feels that the contrast has reached the end of the small bowel, whichever comes first, the radiologist will be called to review the images. On the 15-minute image and on every image thereafter, the cassette will be centered to the level of the iliac crest. The stomach is no longer needed, and the inferior portion of the abdomen may show contrast movement. Timestamps in the form of lead markers or computer annotation should be used. As you can see, the bowels are becoming more highlighted, which indicates the contrast movement through the bowel. Watch the changes throughout the next few images. We've arrived at the 2-hour image. Once taken, the radiologist is called and asked to review the images and give instructions for the next steps to be taken. Depending on the pace of the contrast movement, the radiologist will decide how much longer before he wants another image to be taken. In this case, the radiologist requests another image at the 3-hour mark. After the 3-hour image, many more images were taken, lasting up to 16 hours. For this particular patient, a small bowel obstruction was suspected, not only because the contrast wasn't able to move through the bowel to the terminal ileum, but because of the abdominal and small bowel distension. The patient's small bowel circumference was much larger than normal. Typically, though, in cases where the contrast is suspected of reaching the end of the small bowel, also called the terminal ileum, the fluoroscope is used to image the junction between the small and large bowel called the ileocecal valve. A radiologist is the only person licensed to run a fluoroscopic tower, but a technologist may perform this under direct supervision of a radiologist. A paddle with a pressurized, air-filled center may be utilized in order to move the bowels into a good position for an image, as seen by the white circle in this image. This part of the exam is used as a definitive proof that the contrast has reached the terminal ileum and completes the study. Once the exam is complete, the technologist should release the patient with post instructions. The patient should be instructed to drink lots of water for the following days. Barium is a thick substance that can dry inside the bowels and create an obstruction. If they experience constipation, the patient should seek medical attention. The patient should also be warned that their bowel movements may be white or chalky, and that is normal, and be welcome to call with any questions or concerns that they may have.